One of the exciting things about working with the journal and coming along to something like this is you never really quite know what you're going to get. You never really quite know what you're going to say or what you're going to find when you look into it. And when you look back over the last 100 years of the journal, I had an immense amount of fun. I read every single paper cover to cover, scanned it, of course. I didn't read every word, but I was able to get a snapshot of the last 100 years. And if I could start by concluding that really there were no papers that were awful or dreadful or bad, and actually what you learn over the 100 years is that there is a societal publication pressure that exists that for each generation has its own inadequacies and problems and difficulties. For example, in the 1913 to 1918 sort of period, during that early First World War period, there was a rather unnecessary predilection for trauma cases, for fractures and for isolated instances, which really didn't serve to do an awful lot other than to discuss that particular case. And that actually pervaded for the first 50 years, right up until the Second World War and well into it. And in fact, it was only in the late 60s, early 70s, and really into the 80s and 90s when we actually started seeing anything which resembled what we would consider levels of proper evidence. You're going to hear later on from someone from the Lancet who's going to talk to us, I'm sure, about perhaps how we could improve on what we do even in today. So let's start. I'm going to start off by saying that actually, to be honest, I think we've probably all published papers that are wrong, and perhaps that's a plea for us all to do an awful lot better. But that's just simply a question of perspective. Now, not far from here, as you know, there is a gallery which hangs one of the more beautiful paintings ever painted by El Greco. Fascinating character, and for me, one of the finest artists of all time. But round about the 1600s, as those of you know, well before many of the more famous people who've painted in this style of painting, like Caravaggio, the lady in the fur wrap is an unknown person, but the intimacy that you can see with it is likely to have been Geronima, his long-term partner and mother of his only child. And you can see it's got an immense amount of stylist style for its period. The Boy of the Lighted Candle is also just down the road in Edinburgh, and of course these are the two of the more famous paintings for me, and they hang right here in the midst of Scotland. Now, if you don't believe me that this was a question of perspective, look at our more recent artist, Picasso, enjoyed so much the painting of El Greco that indeed he styled himself upon it. On the left-hand side is El Greco, on the right-hand side is Picasso, and Picasso's sort of copy, if you like. And if you ask me, although many of you would think Picasso is a fantastic painter, I think El Greco is a much better guy. But admittedly, he got things wrong. At the time, he was not necessarily celebrated. He criticized heavily Michelangelo's work. He didn't think that he was a very good painter at all. So things didn't actually work out the way they think. The painting on the right-hand side, which of course all of you are familiar with, they think is mainly based upon the one on the left-hand side of El Greco, that style of painting. So although a guy like him got things wrong, and it really was about 100 years after his death that he was celebrated as a proper painter, it was interesting that at the time they felt that everything was wrong. The Burial of the Count of Ortaz is a fantastic painting, and you can spend hours watching it because of the intricacies and things. One of the things that was criticized, of course, which was typical of his generation, was that the hands were badly painted and completely out of perspective and incorrect. Meanwhile, the anatomy lesson of Tulp, as you can see from Rembrandt's famous painting, also you can see there's an absence of hands, and those hands that are present, for example here with Tulp himself, are badly drawn, inadequately drawn, or incorrect. The more astute of you will have spotted the fact that Tulp is demonstrating the flexor digitorum, and of course that the insertion of this is actually on the other side. It should be on the medial side, not the lateral side, so it's actually anatomically incorrect. So here are artists who spent a tremendous amount of time thinking about anatomy and wondering about anatomy, drawing hands badly and getting the anatomy incorrect. So even masters like this got things wrong. Halsted, nearing the end of his career, was already beginning to grapple with the fact that he thought, in retrospect, do you know what? I think this operation isn't quite as good as I thought it was going to be. And it took many, many, many years for us to, as a surgical society, to actually agree with him and say, you know what, you were wrong. It wasn't a great operation. It was bad. We should have done better. And in fact, it wasn't until the 80s and 90s, as you all know, that we actually had proper evidence that breast-conserving surgery was a possibility. We're now grappling, as Keith has mentioned, with the concept of organ preservation in rectal cancer, etc. But to get down to what you really asked me to do, the specifics of some operations that jumped out for me as being perhaps mistakes or where we could have done so much better. This is one from 1920. You'll notice I've left out most of the names because although many of them are already dead, I really don't think it's particularly fair to do so, because to pick something from 100 years ago or even from 10 years ago is anachronistic at best. This comes under the banner headline at the time of mistakes and errors and the things that you can learn from. And this was a 37-year-old woman who had an open cholecystectomy. She had a bile duct leak. She presented with bile pouring out her wound. They re-explored her and simply sutured the duct. They sutured the duct back together again. Miraculously, she got better. She did discharge quite a number of episodes of bile post-operatively, but managed to make it through it. I suspect if you repeated this 100 times, you would have lost an awful lot more patients than this one. She miraculously survived. They didn't talk about or consider putting in either drains or a T-tube, and I think in a modern world we'd be more likely to put to either internal or external drainage. So there's an example of something which was meant to be instructive, which probably caused deaths because it encouraged people who were not expert in the field to have a go and simply stitch it and see what happens. 1925. The name slipped in, I'm sorry about that. This particular gentleman was talking about peritonitis, and in a fantastically termed and fantastically worded treatise on peritonitis, he refers basically to patients who come in with appendicitis and specifies that the death occurs not because of spreading peritonitis, but because of the bowel obstruction that ensues as a result of the peritonitis. Indeed, he goes on to say that in the second paragraph there, I have already shown, well, he didn't show, he just discussed or spoke, that if peritonitis does not produce obstruction, it may not become universal without being fatal. And if I shall produce evidence, which of course he didn't, that if obstruction is relieved, recovery is the rule in cases otherwise inevitably fatal. And he went on to describe the operation of a tube cecostomy, which of course we've all abandoned, and jejunocolostomy, the purpose of which was to bypass all of that horrible segment that sat down in the pelvis near the appendix. So there's an example of people presenting evidence where there was none, presenting an operation which was daft and ill thought out from the onset. In two papers in 1982, papers back to back, they discussed the possibility of intra-incisional antibiotic therapy rather than it being given in a parenteral or enteral route. Not a bad idea, not a bad concept, but interestingly in the first paper they managed to demonstrate that the serum levels were just as good parenterally, enterally, or into the incision. And then they went on to prove that intra-incisional cefoxitin was a reasonable alternative in abdominal surgery. Well, of course it was. I mean, really, it should only be published as one paper. It really should only have been to say that you can inject it into the wound, you can inject it in the mouth, you can inject it. It doesn't really matter which way you inject it. At the time, we would have been giving metronidazole for an appendicectomy in a rectal version, for those of you who remember. So it didn't really matter which way it was given. It was probably not a great idea. And as a result, I think this, for me, is probably one of the worst papers I've ever seen in the journal, because it's not scientific, it didn't change practice, it was never going to change practice, and it was probably poorly thought out from the onset. I definitely anonymized this one, so I can't even remember where this originated from. The person is still in practice today, I suspect. This is on laparoscopic herniorrhaphy, which strictly speaking was an inaccurate title, of course, isn't it? Because it's not a herniorrhaphy when you're inserting a mesh, but on the concept of laparoscopic hernia repair for inguinal hernia. Published in 1992, and it comes under the banner headline of "When you have a hammer, every problem is a nail." And I think it's worth reading out to you if you can't read it from the back of the room. Surgeons should not rush to adopt laparoscopic hernia repair in the way that they've adopted laparoscopic cholecystectomy. Only randomized, prospective trials will demonstrate whether the method represents an advantage in hernia repair that can be confidently be recommended to patients. Well, there's a number of problems with that, aren't there? I mean, obviously, with the retrospectoscope, we can now say that there is a very clear role for laparoscopic hernia repair in many patients, including recurrences, bilateral hernias, and for many of us, we do it on a routine basis. But he wouldn't have known that then. But even at the time, was laparoscopic cholecystectomy widely studied in randomized controlled trials before we started it? In fact, it's really only in recent times that we have any kind of guidelines for the introduction of new technologies, new equipment, new procedures. So this, even in 1992, I think, was both historically and projected forward inaccurate. And it encapsulates, again, for me, one of the things that is all that is wrong with all of us as a surgical community, is that we're very quick to dismiss something that's new without even testing it and trying it. And yet we're also very bad at saying that our heretofore counterparts were incorrect. But I mean, if you think about it, history will judge everything that we do probably badly, everything we do today. When I started giving presentations, it was with black and white slides. I couldn't afford a 25 megabyte thing that Keith had. Here we are now with everything done electronically. I didn't have to bring a computer today. It was all done just like that. So the world will move on. But everything we do today will be thought of as obsolete in another decade, 20 years' time, whatever it is. Keith has already mentioned gastric bands. I'm sure there are many of you in the audience who'd put their hand up right now and say that history is going to judge gastric bypass surgery badly. I'd be one of them. I think in the future that's going to go the same way as operations for tuberculosis. I suspect next time someone's going to come up with an operation to stop smoking. I call it the bronchoplasty, stapled bronchoplasty. It's bananas. It's as nuts as sewing the nostrils of cocaine users. But there we are. This is what we've got. We're stuck with it at the moment, and whether I shout loudly from a podium like this or not, there are those of you in the audience who think it's a great operation. But gastric band was a good idea, but it didn't really stack up, did it? And in 1999, this group published 302 patients, of whom 277 had a band placed. They go on to say that there were only 2 perforations and 4% complications. But then they go on in the abstract, just in the abstract alone, to say the prolapse of the stomach occurred in 9% of patients, and then they speak of how much reduction in the excess weight there was. Now, when you paste all of that together, that's over 10% major life-threatening complication. If I did that even in my brand of surgery, my hospital would shut me down, and I know that would definitely happen in the NHS. 1999, within living memory, this was published in the BJS. Not quite acceptable. Lactobacilli, the whole concept of probiotics, prebiotics, all of that was all very exciting, wasn't it? It electrified us at the time. We thought this was going to be the new cure for all sorts of inflammatory conditions, from colitis to pancreatitis and beyond. This was one of the papers that helped to propagate that as a concept, because it showed that L-plantarium, in given to patients with pancreatitis, now admittedly the numbers were small, they were only 22 and 23. One of the issues, of course, with all of our surgical trials is that we don't involve enough other centres, we don't involve enough other countries, and as a result, we end up with these underpowered trials. And what it showed was that there was infected necrosis less in the treatment than in the control group, but of course it was wogiously underpowered to show this, and 1 out of 22 versus 7 out of 22 really wasn't enough. And what you ended up with was a conclusion saying that there was less pancreatic sepsis when you gave this, when you gave probiotics, and of course this went on to stimulate other trials, and we know that that one didn't end up as well as we would have liked for the people in the Netherlands, and there was quite a lot of publicity regarding that, neither of whom deserved it, I think. I thought I'd sort of wrap up gradually by telling you some of the research efforts, let's remember, that didn't quite yield the results that we were expecting. There was pharmacological manipulation of ischemia reperfusion. My goodness, who didn't attend an SRS or now SARS presentation in the 90s and noughties that didn't include something about heat shock proteins, manipulation of ischemia reperfusion in some way? I was as guilty as everyone else. Probiotics in inflammatory conditions, as I said, went to the wayside, and really it's only now that we're getting a handle on what we can actually do with these gene mules. Barriers to adhesion formation, wow. That went by the wayside too, and in fact most of the products that I remember being propagated have since come off the market. And gene therapy, of course, being the other one, cancer, which really hasn't borne the type of fruit that we thought it was going to when we talked about this in the late 80s, early 90s. Here are some operations which we've kissed goodbye to already, and please God, we'll be kissing goodbye to a few more in the near future. Thoracoplasty and phrenic crush in my country for tuberculosis was commonly practiced, and you still meet patients usually in final med clinics who have had these operations done. The Patey mastectomy, diagnostic peritoneal lavage. I'm old enough to remember doing this all the time. If you say this now to a registrar, they wouldn't know what you meant. Highly selective vagotomy. Who has not spent time wondering about the nerves of Latarjet, the crow's foot, and all the rest? All gone. Great training operation once upon a time, even in my time. Gone. Proton pump inhibitors killed at stone dead. The Ivolon sponge rectopexy, terrible operation, went by the wayside too. And there are many, many, many more that we could mention. So we should spend a moment reflecting on what we do on a day-to-day basis today that will probably hit the wayside too. I'm going to leave you with some Nobel Laureates from Ireland, all of whom have talked about making mistakes, because mistakes, at least where I'm from, are definitely the portals of discovery, and definitely not something to do anything other than to celebrate, because we all make them. Thank you.